Professor Benjamin Smart from the Center for Philosophy of Epidemiology, Medicine as well as Public Health at the University of Johannesburg joins us now. Professor, a very good afternoon to you. Good to have you with us. So let's first look at the strides as well as advances within South Africa in terms of the fight against HIV and AIDS, from funding for research to treatment as well as new preventative measures we are currently seeing. How are we doing?
Well, we've made tremendous strides, certainly since back in the days of Thabo Mbeki's presidency, where South Africans were denied access to antiretrovirals. Certainly, I mean, since 2010, for example, we've reduced the number of new infections by 58%. That's good progress. We do, though, still have 8 million people in South Africa with HIV. And 50,000 HIV-related deaths every year and 150,000 new cases every year. And so there's work to be done. And I think these UN AIDS targets give us some direction on what we should be aiming for, and they give us a yardstick against which we can measure the performance of our HIV programs.
Absolutely. And Prof, I'm sure you are quite privy to the latest developments around the withdrawal or the halting of USAID. So talk to us about how will this then have a direct impact of some HIV-related programs as well as funding. Minister Motsoaledi just launched a campaign in Soweto in order to expand access to treatment.
Right. So the USAID program, PEPFAR, mostly covered the costs of healthcare workers. So the South African government was already paying for the medication, but a lot of the healthcare workers, well, not a huge number, I suppose 5%, but those 5% were treating 300,000 South Africans every year. And so, of course, these are 300,000 people that need access to their medications, and the government needs to arrange it such that they can. And so what government needs to do and what they are planning to do is to reduce the burden on the healthcare service. Now, what I've heard is that they're going to allow certain people who are on treatment for HIV to get their medication for 6 months rather than 3 months. And that's going to reduce the burden on the healthcare workers. And people that were only getting their medication for 1 month will now be able to get it for 3 months and so on. They're trying to reduce the burden on the workers to accommodate for the reduction in the workforce that the cancellation of PEPFAR is going to cause.
All right. And then in terms of manufacturing our own treatment as well as drugs, Professor, in the advent of ever-improving technology, with the launch of Viatris's local AVR production being noteworthy last year. But, I mean, South Africa still faces quite a significant challenge then in reducing the new HIV infections, with young women, unfortunately, being at the higher end of that particular bracket.
Right, that's right. As I said, we still have 150,000 new cases, and the majority of those are young women, typically infected by men that are a good 10 years older than them. So I think two things need to happen. The first is a cultural shift. You know, it needs to no longer be okay for that kind of thing to happen, and we're all aware of the gender-based violence problems in South Africa. So the first is a social shift. The second is provision of preventative care, so prophylactic treatment. And unfortunately, PEPFAR and USAID played a major role in that. So you can take pills and have injections that prevent you from getting HIV in the first place. And this was going to be a major part of our battle against the HIV epidemic. And so not only must government provide medication to ARVs, but they must also find a way to cover the loss in preventative care.
And speaking of those losses, Professor, that need to be covered, I mean, we are hearing news of the NHI being well on track to be signed into law and finally implemented. So, but how are we faring in terms of health services as well as management standards as compared to our immediate neighbors? It's actually quite interesting that the US had last year committed to buying some HIV drugs through African suppliers through this USAID as well as PEPFAR funding initiatives.
Yes, I mean, I must say I'm not massively familiar with that. I do know that South Africa produces around about half the ARVs that are here, and that, you know, the major benefit of this is cost implications, but the reductions in cost from producing locally only really help if you're producing the ingredients locally, and we're still not doing that. So in terms of manufacturing and production, some strides still need to be made, but government are well aware of this and making progress in that regard. And of course, you know, South Africa's, you know, this is close to South Africa's heart, because we have probably the highest population of HIV infected people in the world. So this is where HIV drugs should be produced.
Absolutely. Professor, we really appreciate your input this afternoon. That is Professor Benjamin Smart there, medicine as well as public health at the University of Johannesburg.